Anyone, welcome to you all. We have with us voting members of the TAC, Valerie Mudd representing consumers of mental health services, Diane Shermer representing the Brain Injury Association of America Kentucky chapter, Sarah Kidder representing the NAMI Kentucky, Steve Shannon representing the Community Mental Health Centers through CARP, and I'm Sheila Schuster representing the Kentucky Mental Health Coalition. And Gail, if you have joined us, speak up and we'll introduce you. So we have a quorum. I distributed the minutes to you all, the draft minutes. So I would entertain a motion from somebody, a voting member.
Gail. Sorry.
What'd you say, Charlie?
Gail just joined.
Okay, great. Hi, Gail. So Steve made the motion to approve the minutes. Is there a second?
Second.
And who was that, please?
Sarah Kidder.
Sarah, thank you very much. Any additions, corrections, omissions? All in favor of approving the minutes signify by saying aye.
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 Right. And opposed and abstaining. Thank you. I'm not sure who all we have on from DMS. Leslie Hoffman, I think, Dr. Terrio, the medical director, is with us. Who's going to do the update on our data request for Medicaid on targeted case management?
I think Leslie Hoffman has that. And
This is Leslie.
Hi, Leslie.
So I talked to Barbara. She has the data, and then I've emailed you. Of course, we're going to schedule probably a 90-minute meeting sometime next week, if that works for you, Dr. Schuster.
Yeah, I've sent it out to our little work group.
Okay, and as soon as you can get me some dates, then I'll help coordinate that and get
Okay.
it scheduled for you, okay?
Yeah, so that makes it sound like we should be able to present some data at our November meeting then.
Yes, ma'am. That does sound, I haven't seen the data, but Barbara felt pretty confident that she had enough to give you that would answer some questions that you all had.
Wonderful. Thank you very much. Yeah.
Okay.
So for those of you who are new or may not remember, Commissioner Lee, Medicaid Commissioner Lee, a year ago at this point, when we were talking about targeted case management and the importance of it as a covered service for people with severe mental illness, really urged us to dig into the data, of which Medicaid has a lot, tons in fact. And so Dr. Brenzel from Department for Behavioral Health, Developmental Intellectual Disabilities volunteered. And we pulled in a couple of other folks who have been particularly up on this issue of targeted case management to join on this little work group. So what we're looking at is the Medicaid data, and we're trying to look at people with severe mental illness before they got targeted case management and then after they got targeted case management, to see what the utilization of services was, and also to see what kinds of hospital or ER visits, whether people filled their prescriptions, some of those things that we know really make a difference. So that's exciting. Very happy about that. And thank you for coordinating that, Leslie.
Not a problem at all.
Okay. Charlie, I think when we get to the medical respite, which we're going to get to here in just a minute, I think that Tom Moulton is going to be able to, you have to make him a co-host so that he can share his screen.
yes, what was his name? Tom?
Tom Walton. He sent you an email with it earlier this morning.
I don't think I got it,
Oh, huh.
but I've made him co-host so he'll be able to share.
Yeah. It's tom.walton@louisville.edu.
Yeah, I didn't get anything from him.
Huh.
I don't-
Well, okay, but as long as he can, when we get to it.
Yes,
Thank you. Let's see, I think Lee Geis was going to pick up on this next item, the update on claims payments for services to people who are dual eligibles.
Yes, ma'am, and good morning.
Good morning, good afternoon even.
Let me see if you can actually, well, I can't show you my face today, I'm sorry. Because once I open a Zoom meeting, I can't get it moved off of the screen it's on. The claims payments, what we're looking for is the bypass list, right?
Right.
On there for, we certainly, it is in process right now. On Friday, I have another meeting on Friday that is a meeting where we prioritize the release dates for all of our change requests. And that change request will be on the list, but I do not know what I can send an email to you, Dr. Schuster, on Monday about when we anticipate it to be implemented. Okay, so we're looking right now, it's September, so it would probably be no sooner than October for it to be implemented.
Okay, and let me just be sure that I understand, Lee. This is the excuse me. This is the list that would tell people how to code so that they could bypass that requirement to have a denial from another insurer.
It's not necessarily how they can code, but it's something that we put into our system so
Okay.
that the claims won't deny payment.
That's even better.
Right, right.
So
And
this
Sheila?
was, yeah,
This is Steve Shannon and Lee, the MCOs will get that as well.
Yes,
Is this the Medicare bypass list? But this is the bypass list, right?
it's the Medicare bypass list.
Medicare. So we still struggle with commercial insurance.
You're going to struggle with commercial insurance. It's my understanding that the Medicaid Medicaid members have hundreds of different commercial insurance plans, and we just do not have the ability to give a listing and code that listing into our system on the commercial side. So when I said something about commercial, I think it was to this group.
Yeah.
You should have now go back in your mind and picture me opening my mouth and sticking my entire left leg in there, because that was an inappropriate use of the word commercial.
Yeah, we still struggle with that issue. I don't know what the resolution is. Guess we'll keep at it, but you know, targeted case management is not a covered service with anyone but Medicaid. And you know, we keep, you know, and it's really, I don't know if Kathy Adams is on, but it's a kids issue as well. And you know, kids have commercial insurance that pays for some things and Medicaid that pays for, you know, other stuff. But you know, I still, you know, and it's been a decade. I don't know what to do when, you know, they expect us to have an EOB and we're never going to get an EOB for services that the commercial carrier doesn't cover. So I don't know. Keep at it, I guess.
Steve, I'm on. This is Kathy Adams. And yes, it's a continuing issue. We do have a few members that are making some progress, so you and I can talk. But I think one clarification I'd like from Lee is I followed up with all the MCOs following our last meeting, because about 2 years ago, a year and a half ago, we had gathered bypass lists from each of the MCOs. And before I shared any of that information, I wanted to go back to the current MCOs and see if they had one, and if, compare their current one to their old one. Several MCOs, when I asked for their recent bypass list, provided me 2 lists, and they said, this is the Medicaid bypass. Medicaid, this is DMS's Medicare bypass list. So what you're telling me is the 2 lists they provided saying that those were DMS's Medicare bypass list, those are the currently existing. They are not the new ones, because the new ones haven't been implemented yet. Is that correct?
I don't know what they gave you, Kathy, so I can't comment on that.
I forwarded it to you all a couple of times.
Okay. I just haven't had the opportunity to take a look at them, to compare them.
Well, Have the new list been shared with the MCOs yet?
Angie, are you happen to be on this call?
Yes,
Leslie?
ma'am, I am. I mean,
I
there
don't-
is a Medicare bypass list on our SharePoint site that the MCOs have access to. I can't verify your list and the new list, but if the new list is out there, then yes, they have that.
And that's what we don't know, because we don't know if it's the new list or the old list, if you all have shared the new list with them yet. Because again, our members are taking those lists and then having their third-party biller implement the bypass code list for them.
Mhm.
So we don't want our members spending money to have the old list done if the new list is coming out in October. Does that make sense?
Okay, I'm not talking about the list, Kathy. I'm talking about implementation in the system. Okay.
Okay,
Which
so
are
is
often
there a
two-
list available, a new list that has, I guess, so the new list exists, but it hasn't been implemented in the system? Is that what you're telling me?
Well, I'm not the person who puts that list together. So Leslie, are you I'm sorry. I'm sorry.
I'm
about
on,
that.
and I'm trying to figure out how to answer the question. I know Ann said, Ann had worked on a list for system changes. I don't believe that was implemented yet, because even as of last week, I think she was still getting questions about additional things that needed to be added. So as far as I know, it has not, quote, been released in the system yet. So I can
I know
follow up
it's-
with Ann.
Yeah, I know it's not released in the system.
Yeah.
Okay.
That was my understanding. And as of last week, she was still getting emails and questions about certain things that we were having to follow up on, to ensure that they were included or weren't included, or a modifier maybe that needed to be included.
So I think then we can say, Kathy, that the list that is posted is not the new list. We've had a Medicare bypass list for a while, but it's not the new list. Is that fair, Leslie?
Yes, ma'am. I think that's fair. And I know that's not what everybody wants to hear, but I can tell you that at least it's being worked on, which is, it's a big endeavor for her to have taken that on. And she has been diligently trying to get it completed.
This is Steve Shannon. I'm trying to understand, because I'll get the same questions Kathy will get, I'm sure, from our members. So on Friday, there's a meeting to do the system changes that will probably happen in September and will go live for Medicaid in October. What is that information?
Okay. What I was trying to tell you is that I can't give you a timeline
Yeah,
for when the system changes will be made. There is a change order already in process, which is how we make our system changes. Okay. I have checked all of the relevant material I have, and I can tell you that the group that sets the release dates, which is what we call implementation, meets on Friday morning, this Friday morning, as it happens. And we will set a release date for that change. I will make sure that a release date is set for that change order this Friday. And then I will know. It's too late for it to be September, particularly if Anne is still working on additional changes. So the earliest I believe that the system change will be made could be October, the end of October.
Okay,
That's for the system change.
right.
We
But I
will get
get,
back with you. We'll have to get back with you on when we believe the list itself can be posted.
but the system change is driven, the change is the list. Is that true or not? So
Well,
when
yes.
Ann finishes her work, right, Leslie? And it is a huge job. That will be the change made to the system, is that list?
Yes.
Okay.
Yes, that's correct, Steve.
Okay. So there's two pieces. There's the change order timeline, and then there's the work by Ann to really is what the change will be driven off of Ann's work. Is that correct? So those are the two things that need to happen.
Yes.
Okay, so Ann finishes her work and then the system gets whatever, and we're hoping maybe that's October. Okay,
So this is,
Yep.
Lee, you would notify me after you have your Monday or your Friday morning meeting
Yes. I'll send you an email.
about a date. Okay,
Yes.
thank you very much.
You're very
Somebody
welcome.
else had a question or?
yeah, it was Kathy again. I'm sorry. I just was curious if you all had any idea the differences between the list. Are we talking just a few tweaks? Are we talking major changes? Again, I assume we can go ahead and implement the list that's posted on your SharePoint website. That's what is in the system now, correct?
This is Leslie. Whatever's posted right now would be your best bet. I can't tell you myself today what the changes were between the two lists or two system changes.
Yeah, and if you all would like to see that, if you could put it on your next agenda and so that we could have some time to prepare that, we would be happy to do that for you.
That would be awesome.
I agree.
Well, thank you, ladies, so very much. We know it's a lot of hard work, but we, again, working off the old list, I think, and being able to get those codes to bypass when you provide those services is helpful. And then maybe once we figure out what the new changes are, it won't be as drastic for our members to implement the new things if they're identified.
Right. And Lori Gordon asked in the chat, go ahead, Lori, sorry, I'm not speaking.
No, I was going to ask it out loud.
Yeah.
Hi, everyone. So I have two clarifying questions, I think. One, are we calling what you all are referring to as the old list, the 12, 17, 20 list? Or are you referring to the 2016 as the old list? Like, how old are we talking for the old list?
This is Leslie. I'm not sure which one's posted right now. And again, I can ask
Okay.
Ann and we can follow up on that.
Okay.
Or
and then my
Angela,
second,
if you're able to tell us which one's posted.
Okay. And then the second part of that question is, so if the new list is coming out, which I'm assuming is like what you all are working on now, then if the change order is entered in October, is that when the MCOs will be notified? And then just as a reminder, if that is when the MCOs will be notified, then they will also take some time to implement, just as a reminder.
I believe that we're required to give you 30 days notice. Aren't we, Angie? So we wouldn't wait until it was implemented in our system to give you notification on that?
Right.
I would hope that if you all set a change order date on Friday and it's Halloween, seems to fit this topic, that as soon as you knew that, you would give the MCOs a heads up? Does that constitute the notice that they need?
We have to be able to give them the list. Dr. Schuster, we have to be able to give them the list. So we have to have the list finalized.
Okay,
At that point, then I believe we would give them notice.
okay. All right, so it's not like a full 30 days after the point at which it gets into your system, I guess is my point. It could happen earlier than that.
Yes, ma'am.
All right, great. And in terms of our November agenda, Lee, since you have offered to do this, are you prepared to come and talk then about the new list and the process and so forth? Is that what you were suggesting?
Well, I'm prepared to make sure that we can show you a chart or a file that has a comparison between the last posted Medicare bypass list and the newest one. So
Right.
that you can see, and that someone will be here to talk to you about it, whether it's me or someone who knows a little bit more about coding.
Or Ann or somebody, yeah.
Yes,
Okay,
ma'am.
that would be great. So not to beat a dead horse, but I want to go back to the commercial plans for a minute, because I understand the problem in trying to have some kind of a bypass list that takes in every kind of commercial plan that somebody might have. But I think Steve raised a really good point, and that is that there probably is not a commercial insurance plan that pays for targeted case management. And if we were to find that that was the case, I guess my question is there some way that the provider can indicate that, I'm going to try to build the insurer, but I'm sure they're not going to. They're not going to get an EOB because it's not a covered service,
Right.
and can go to the MCO at that point.
I think, Dr. Schuster, this is Angie Parker, and I'm not going to speak for the MCOs on how they handle that. But I guess I have a question is, for example, you as a provider provide targeted case management. Do you build that to the commercial plan?
No,
So if you were to bill it to the commercial plan, then you would get a denial back, correct?
no, we would get
No.
nothing back.
You get
That's
nothing
because
back.
They're not denying the service they don't cover.
You can't get EOBs for a lot of the behavioral health services because they don't cover it. So
They
it's
don't
not
cover peer
technically.
support. They don't
Yeah.
cover community supports. So they won't deny something they don't cover, because denying it is the implication that it is covered. We're just not paying for it in this situation. So our
Right.
experience has been, we don't receive an EOB. And therefore we can't send that. And I think Kathy, and I think some of my members done the same thing. Here's a list of codes that our billing folks, our third party, if we go through clearinghouse, can maybe help with. But the reality is we get zero information. It's much like sending a dental claim to your car insurance. They're not going to deny that dental claim because they don't pay for it. So we get nothing in response. We get nothing from Medicare. Hopefully that's addressed. We get nothing from commercial insurance. For those services, they do not cover. And therefore, our friends at the MCOs, they don't want to pay for something as pay or last resort without a denial. We can't do that. We're just never going to get a denial for those services.
Right.
And therefore,
That's
we're
odd
kind of
because,
flat.
I mean, I'm sorry. I can't believe, I mean, I'm sure you're correct. It's just that you would bill something and just ignore it because it would be a benefit exclusion. So they would have to.
They do.
And having worked for an insurance company, they typically will send you a denial and the code is not a covered service.
Right, that's what I'm amazed that that doesn't happen with the behavioral health.
10 years we've been discussing this topic with our friends at the MCOs. You can ask them. Lori Gordon and I have probably said meaner things to each other than any other person around this table. You know, but that's the reality. We do not get them. And whether it's, you know, their expectation is they'll send an EOB, not a covered service. That's not happening.
And
If
this
that was
is
happening, we
Kathy,
wouldn't have a problem.
and this is Kathy with the Children's Alliance to just say that Steve is 100% accurate. My members experience the same thing. They do not provide you an EOB, and the MCO will then not pay you for that service. So thus, that's why some of our members have had to stop providing services to people that have primary commercial insurance, which, as we noted in our last meeting, was just horrible that people that have two insurances are actually getting fewer services than those with just one.
Bart, did you want to say something?
Yes, thank you, Sheila. Just a couple quick things. One is this across all provider types. I mean, CMHC, PHSOs, multi-specialty groups.
Yeah.
You know, we work with all the above, and they all experience the same thing of not being able to get the denial. The other thing is that I was the one working on this last week, and nothing I sent in wasn't already on there, so that's not going to delay things. So just to clarify that. But she also said that there is, if you're billing Medicaid, straight Medicaid, there's a form in the MMIS billing manual for their provider type to fill out if the code's not on there. And now that's only, and that's only for billing. Now that's for commercial, my understanding, if you're billing straight Medicaid, which is probably happens, but not nearly as much as commercial and MCO. So I think that's where.
Have you guys considered asking the MCOs if they would follow that same process with you?
This is
I actually
Kathy.
provided, this is Angie, I actually provided that form to the MCOs back in July after our last behavioral health TAC.
And this is Kathy Adams. Our members use that form. It was April, probably 2 years ago, that they were using that form, and then all of a sudden MCOs stopped accepting it. And we could not find out why. And then the pandemic hit, and anyway. So yes, it's the TPL form, third party liability.
Well, let's, this is obviously not going to get solved today, and I want to move on to the medical respite. Let's put two parts of this on the agenda for November. One is to get a briefing from DMS on the filer chart and the comparisons. And then I'm going to request through DMS that the MCOs come and report how they are handling these billing issues. Okay. I know everybody will be thrilled about that. All right, let's move on to a new topic that I think is super interesting and something that we need to pay attention to. And I'm going to turn it over to Adrian Bush from the Homeless and Housing Coalition of Kentucky to introduce our speakers, a father and son team.
Thank you so much, Sheila.
Sure.
And thank you to the Behavioral Health TAC for having us. We got started really working on medical respite. And by medical respite, we're talking about care for people experiencing homelessness once they are discharged from the hospital. We don't want to discharge them back into homelessness, whether it's on the street or in a shelter. And sometimes people need like mid-level, but they are well enough to be discharged. They are not well enough to be living on their own. And so couple of years ago, pre-pandemic, I guess that probably feels like 10 years ago, we got in touch, or they got in touch with us, Tom Walton, who wears a couple of different hats, but is with the University of Louisville, is an executive resident, but also is part of the Louisville Health Advisory Board Community Coordination of Care Committee. And so he had gotten in touch with us and we were like, hey, there's something here. The Kentucky Interagency Council on Homelessness, which HHCK facilitates, we'd had a number of providers report that the medical respite was something that they wanted to work on, that they saw a need for. So with that, I'm going to turn it over to Tom and Matthew and whoever is here. That's the thing with Zoom meetings. I'm never quite sure who's here and who isn't. But anyway, we're really glad to have you on board, Tom, and anybody else you want to introduce. Or if you just want to go through the slides, that's great too.
Sure, I'm going to run through these slides really quickly so we have a little bit of time for discussion. When we started, we actually have some people on the Community Coordination of Care who do street outreach. And she took these pictures, and these are places where people are actually recovering after hospitalizations. When we talk about medical respite, another term that's used is recuperative care. We use the term respite, but no, in this situation, they're pretty much interchangeable. As Adrian mentioned, this is part of the Louisville Health Advisory Board, which the whole advisory board is about 80 organizations. The Community Coordination of Care is about 30 organizations, and we have 3 work streams. One is to screen for unmet basic human needs. We were really instrumental in thinking about screening for health systems, food banks, et cetera, for these more commonly called the social determinants of health. We also do a lot of work with navigation. We did a lot of the thinking behind the United Community, which is the community-wide navigation systems that's run by Metro United Way. And then we realized you can screen and you can navigate, but unless you have capacity, you really have not served the needs of individuals. So we're working to increase capacity and coordination in the areas of food, housing, and transportation. Our larger initiative is called Housing as Health, because on our committee, we have Norton Healthcare, New Directions Housing Corporation, people from all over the spectrum of health and human services. So again, we're very interested in affordable housing, we're very interested in addiction prevention, but this specific project I'm going to talk to you today is about respite care. And then as Adrian mentioned, we were talking about this in the Louisville, I'll call it the LHAB, the Louisville Health Advisory Board, and they said, hey, you guys need to go to Frankfurt and talk to the Housing and Homeless Coalition. So we've been working together since then.
Tom, can I interrupt for just a
Sure.
second? I had a question in the chat. Will you, are you willing to share your slides afterwards?
I
with
am.
people? Okay, great. So I can send them out to everyone on my list. Thank you very much.
A lot of the research we're doing, we are in love with the National Institute for Medical Respite Care of the National Healthcare for the Homeless. They have a lot of research on, quality standards, outcomes, implementation manuals, et cetera. We look at a lot of academic and industry publications, and we're very interested. We've actually applied for a Robert Wood Johnson Systems for Action grant to address the wrong pocket problem. A good example of that in the housing sector is if a child lives in a home with a lot of, rotting carpet and mold and keeps going to the ER with asthma. Well, it really is the MCO that's paying for that. However, it's the housing sector that's generating the cost. So again, we're looking at that. And part of our reason for being so focused on that is we're very interested in sustainability. Just about some of the conversations that we've had. We had 3 design, we call them design calls. One of the calls we had the voice of the client, people that do street outreach, health systems, MCOs, et cetera. As Adrian mentioned, the Kentucky Council on Homelessness, we've talked with Commissioner Lee, Leslie, and Angela. Then we also report about this work bi-monthly to the full LHAB and also in our Community Coordination of Care, the Homeless Task Force. And then there's highly possible that I've talked with you about this before. If you work for a health system, MCO, the Kentucky Hospital Association, et cetera. In other words, we're trying to get as broad a representation of the stakeholders as possible. What I'm going to ask you today is we really need the expertise of Medicaid and all of you who are on this committee, and particularly your lived experience experts. Those are the people who are experiencing homelessness or have experienced, because what we believe is that they need to be hardwired into the decision-making process for respite care for really to be successful and to meet their needs. This is the why. We have some data from the health services and facilities data, and you can see that there's over 11,000 people experiencing homelessness. Again, this is statewide data, and a readmission rate of 3,700, which is about 33%. Again, coming out of the hospital sector. So again, if we had this level of readmission, we'd be extremely concerned. The reason we're talking to you all today is we also have looked at the MSDRGs. Again, there's over almost 11,000 cases where the discharge diagnosis was documented, the DRG was documented. 60% of those had a psychiatric diagnosis, and by far the most common diagnosis was psychosis. So we believe that a respite program really will serve the populations with which you all are concerned. When we want you to be involved, this is sort of the how. We're setting up these 3 work groups to develop a strategic framework. One, we're going to start with the unifying goals and shared measures. And again, I'll talk about each of these in a little more detail. The second is practice models, and the third is payment models. So again, I have written some possible goals here. I want you to know that we're very interested in co-creating this framework with you all and with other stakeholders around the state. But I thought it would be helpful to tell you some of the indicators that are in the literature. The number one, which impressed me, was the improved quality of life. You know, we tend to jump into like reduced cost and all that kind of stuff, but the literature very, very strongly suggests that you will have a lower mortality rate, your fewer unsheltered days, less disease burden, et cetera. Again, I'm not going to read through all of these, but I do want to talk about appropriate utilization. And the number one thing that people look for in a respite setting is the connection to primary care. So they in fact can break this cycle of, you know, using emergency rooms as their primary care site. People also look at stable housing and better value. And again, when you, again, coming out of the hospital world, I'm always looking at readmission rates and length of stay and things like that. But again, we're looking for a very holistic set of measures. The second area is these practice models. Again, I can talk a lot about these, and this is my let's start now, that we don't have to wait for a dedicated respite facility. Each community around the state can start thinking like, how can we better coordinate services? You know, in Louisville, we actually started back in 2012. We had these community-wide case management conferences where we looked at people who were familiar faces to multiple ERs and hospitals, et cetera, and started to develop sort of community-wide care plans. It was really, really successful. Now, again, that was the technology is much, much better now. And, you know, in the Louisville market, I think Aetna Better Health uses it across the state as the Unite Us platform. So it's much easier to do these kind of navigation services. Some people, again, in Lexington and around the country use this temporary setting, a hotel, shelters, et cetera. There's also models where they have dedicated facilities. Some of them are staffed with providers and registered nurses, you know, 24/7. Some are more non-medical, which means that the providers come in to provide services, but they don't necessarily have 24-hour staffing. We also know from looking at the data that recovery is a really significant issue. So there. And then the model, which I'm actually quite fascinated with now based on this study from UC Davis, is this integrated co-located patient-centered model. And that's where you have a campus very similar to these continuing care campus for older adults, you know, where you have assisted living, independent living, permanent supportive housing, et cetera. And again, I'm have to constantly thinking about, you know, efficiency and how do we pull services there. And again, I'm going to go back to this idea of having the clients themselves participating in the design of the services. The last area is the payment models, and we can thank our friends at the National Institute for Medical Respite Care and United Healthcare for funding a paper on different payment models. So I've referenced that here. But again, there's all sorts of payment models. The reason that this is really important right now, I'll just tell you, in Louisville, the family health centers, the Phoenix Healthcare Centers for the Homeless, are using part of their Health Resources and Service Administration, their HRSA funding, to stand up a new respite location at Hotel Louisville. We will be looking at the data on that very, very closely. And the reason for that is we want to, document the fact that this is the sustainable business model. And again, this goes back to the wrong pocket problem. We could ask a health system to invest really hundreds of thousands of dollars in adding new case management, but unless that benefits them, we just know it will not be a sustainable model. And then I think undergirding all this, I don't have a slide on it, but is the ability to talk about the technology to link all of this together. Again, we, the Epic system has care everywhere that can do things. We have United Community, but again, to be very intentional about how these different systems can be linked, systems of care can be linked using technology. And the last is, these are sort of the, in addition to participating on these work groups to design the strategic framework, we're really interested in each organization going back and looking at your engagement with people experiencing homelessness, because we do know that, we all have balance sheets we have to pay attention to in profit and loss statements. But again, to go back and look at what makes sense for your organization, talk about your North Star. Also, we do have our next virtual planning conference is on September the 30th at 10 o'clock. Again, this will be in the slide, so you're all welcome to attend that. You can email me at tomwalton.louisville.edu, and I'll be glad to send you an invitation. But the Phoenix Healthcare Center for the Homeless is going to be talking about their model for respite care. And again, they looked at their data and the data that we're supplying, and they are really going to hardwire mental health services, into their program, because we know that's a really critical phase. And then you're always welcome to join the Louisville Health Advisory Board, Community Coordination of Care, and hear us how we flesh out all of this work. Any questions? I think we have a couple minutes left, or Sheila, I'll yield the agenda to you. I know.
Thank you very much, Tom. And I appreciate having had a chance to talk with you and your son, Matthew, and Adrian. I guess from a behavioral health standpoint, because obviously we have problems with people getting discharged from the hospital purely on the behavioral health side, and not getting that, what we call warm handoff, or the, connection back into the community, which is a problem. But you all are focusing, I assume, mostly on people that are being discharged from the hospital for a physical health reason?
No, not at all.
Okay.
I can looked at the data, and it really is the large psychiatric hospitals that have the highest readmission rates.
Yeah.
What we'd be really interested in, again, I might use these little lingo-y terms from the healthcare world of, systems of care. We're very interested in designing systems of care with the idea of no wrong door. So in fact, you can enter any way and navigate out to the most appropriate resources. I think the thing that we are going to pay a lot of attention to though is the medical discharges, where we've pretty much ignored the behavioral health components.
Yeah.
And I think that's the big add here.
Yeah, I think that's interesting. I mean, one of the things that we've only been asking for it for 15 years or so is a Medicaid waiver to address our folks with severe mental illness, and it would have a housing component, a supported housing component. And I wonder, Tom, if medical respite couldn't be a part of that.
Mm-hmm.
I mean, it makes sense because it's our SMI folks that are in that revolving door in and out. And we know that they also have significant physical health problems, because they die 25 years sooner than their same age peers who do not have an SMI.
Right.
So that could really be a place for at least some of this to land, at least for those folks.
I'll send you a link to that UC Davis paper. I mean, it's about 100 pages, and usually I just, quite frankly, just blow through those things. I'm reading it in great detail, and it outlines models from around the country and different approaches that they've taken. And again, this is where I think we really have to hardwire the voice of the client into it so that they have some decision-making process to some, they are involved in the decision-making process to choose the services and the system of care that most benefits them.
Yeah. Diane, you had your hand up. This
Yes.
is Diane Shermer, Tom, who is with the Brain Injury Alliance.
I just wanted to say that we'd like to get more information simply because we serve the military and we have a grant, and there's a high percentage of military individuals who are homeless, both with hospitalization and without. But we have to address those issues. And so I'd love to get more information and somehow get us involved.
Oh, that's wonderful. Thank you.
So I need to make sure I get your email.
Sure.
Tom, if you want to, type your email in the chat there so
Okay.
people can, we used it earlier. Are you using your Tom Walton at Louisville.edu or another one?
That's the best one. Yeah.
Okay. Yeah, why don't you go on and put it in the chat? So you met with some folks at Medicaid. How do you see this being implemented through Medicaid? I guess they would have to put it in the contracts.
That would certainly be one way to do it. I think we also need some technical advice on like how to bill it. Like, do you bill like a room and board charge? I mean, I think probably be okay with billing for the medical services. Would also be really interested in some demonstration projects about the use of telehealth. And again, I'm going to put on my rural healthcare hat here and think like, could you in fact have somebody discharged from Lexington and return to Somerset, and then, link back into the specialist in Lexington so that they can, do the respite care in their respective communities, and to see how that sort of would work. Again, we just know that transportation from our general community coordination of care is a very, very significant issue. And when we go back and look at the United Community data, transportation is probably one of the top 3 services that are needed.
Yeah, and we certainly have learned to rely on telehealth during this pandemic, and it works for the majority of the people. It certainly doesn't work quite as well for some. But any other questions? If I can't see you, just jump in, because I can only see a few people. If
I have a
anybody has-
question.
Yeah, who's this?
It's Val. I have a question.
Yeah.
I know it's different for everybody, but I think specifically about I think specifically about our population of folks who are in the revolving door aspects. How long does the respite last? Or, if they go back in the hospital, do they get respite again when they come out? Or how? I need a little clarification on that if you can.
So I'll refer you to this paper, but and the reason for that, there's a chart in there that gives the length of respite time. Like some have an average length of stay of 20 days, some have an average length of stay of 91 days. But again, I think the idea of this integrated campus is really attractive because people could move amongst that campus and see the same providers. We also believe that nursing homes will be more willing to accept people with medical needs if they know that they're not going to get quote unquote stuck with them, that they could be transferred to a respite setting after their nursing home kind. But it really does vary. And again, part of I'm going to put on the work stream hat is the ability to assess people's housing status. We looked at one study in Philadelphia where they had a very high readmission rate in the first 7 days, and they went back and they did not assess housing status, while the person was in the hospital. So they just were not thinking in terms of they weren't considering the context of the patient.
The other thing too is we want to be careful with respite programs and designing respite programs that are not just another place to warehouse the homeless and the mentally ill. That this is just a point of contact, a place for people to go to get the care that they need post-hospital, but also get them connected to permanent housing and prioritized for permanent supportive housing or rapid rehousing, whatever the appropriate housing intervention is.
Yeah, thank you, Adrian. I had in my notes to talk about why the title respite to residents.
Yeah.
Yeah.
Very intentional that it's a point of intense care coordination that occurs while they're in respite. And then the idea is to move them to spend at least a year with them post respite and to navigate into, you know, permanent supportive housing or the most appropriate housing situation for them. So thank you. Whoops, forgot that.
No, you're fine. That's why Tom brings the healthcare piece and I bring the housing piece. That's why we work well together.
Yeah, that's great. Any other questions?
Well, you know, I was just going to say that when you talk about something like that, in brain injury, there have been projects across the country called resource facilitation, which are those wraparound services that you're talking about that really are in communities to help link the people with the resources to give them the ability to be successful in the community, whether it's housing or vocational opportunities and other things to get them successful. And so I'd love to dialogue more about this because I have a pretty good working knowledge of how resource facilitation works and building those small communities. And I'm linked up in Kentucky with others that have that interest.
That's wonderful. Thank you.
Yeah. Thank you so much, Adrian, for bringing this to our attention, and Tom for putting together the slides, and delightful to get to meet your son also, who is a data geek for the state, which is great. You are welcome to attend our BH TAC meetings anytime. And obviously housing has been high on our priority list. I'm looking at Sarah Kidder here. That's one of the things that NAMI has been on for years and years and years. Steve Shannon and I have been advocating around that Medicaid waiver, you know, for supported housing. And this obviously is a piece of it that needs to happen as well. So we thank you very much. And with your permission, then I'll share the slides back out to people that are on today.
Thanks for your time.
All right, thank you. Appreciate it. Thanks, Adrian. We are revisiting an old topic, but one that has been interesting and is still unresolved, and that's the issue of ambulance or EMS transportation of individuals with behavioral health issues. And if some of you may remember, we used to have probably, well, it was in the previous administration, so it was 2 years ago. We used to have these discussions about people would show up at an ER at a hospital that didn't have a psych unit and want to be admitted, and the folks at the hospital felt like they ought to be transported safely, even though it was a voluntary commitment. And EMS would either not show up or say they don't have to take people with mental health issues or something like that. So the Kentucky Hospital Association is working on this issue very hard because they're having so many problems in getting hospital to hospital transfers and so forth. So I just wondered if anybody on the call had any examples or anecdotes that you could share briefly.
I have one with my teenage daughter.
Okay, what's that?
In the last year and a half, she's been in and out of psychosis. So we had to call CIT team, and CIT wasn't allowed to touch her. And then the ambulance and fire department showed up. This wasn't even at the hospital, this was at our house. None of them would touch her. They were just standing there watching me guide her and chase her down the road. And she ran in front of multiple cars because they wouldn't touch her.
Huh.
Yeah, so there's a little bit of misguidedness on whether they should touch or not touch, as well as transport. They ended up transporting her because she was clearly in a state that was not safe, but until it was proven, they wouldn't do anything.
Are you in urban, rural? What
I'm
part
in
of
Louisville, Kentucky.
Louisville? Oh, wow.
And even with the CIT officer there, they still wouldn't touch her. And on another occasion, they said they wouldn't touch her.
Huh.
I was able to get in the ambulance with her and escort her, but they weren't allowed to put handcuffs. And I don't know if this is just a teenager rule or if this is a adult as well rule, but it's happened twice.
Okay. I'm sorry it's happened. That's a great example. And Jeff, you have something to add?
Oh, whoops. That was my dad's name. I forgot to change
Oh.
it. My name is Cree Van Sloan. I just got this computer from him because mine died yesterday.
Oh, okay.
My apologies.
That's all right.
Yeah, my name is Cree Van Sloan. I am from Mental Health America of Northern Kentucky. And we currently are offering free mental health first aid. I will leave the person's contact email in the chat if anybody would like to send it out to first responders or they themselves would like to take mental health first aid. We are offering it virtually. So yeah, I just thought this would be another resource that folks can utilize. And
Okay.
thanks for letting me share, and I will change my name.
Okay. And Tom Walton just put his email address in the chat. Somebody was looking for it. Tom.Walton@Louisville EDU. Any other EMS stories? Thank you for sharing that. All right. If you hear of any or become aware, just send me an email, kyadvocacy@gmail.com, and let me know about it. Thank you, Marcy. You just put it in the chat for me. Lee, I think this is you, the update on the NoShow data gathering panel and how the data will be used.
Yes, ma'am.
Thank you.
What I have are a couple of reports that I've received. What I can't tell you is how it's going to be used, other than to tell you we're going to be sending reports to MCOs on this. I think the testing on this has been completed, but the I don't know if they've begun sending the reports live right now. What I can tell you is this, and I can share a listing with you on my screen if you would like for me to. But
Yeah,
what I
if you
what I
would
can
do
tell-
that, Lee, that would be great.
Okay, Shirley, can you give me the ability?
You already are, Lee.
Okay, great, thank you.
Mhm.
Too many things open on my computer. Let me see if I can make it a little bit bigger. Oh, too much bigger. I don't know how to zoom in here, but I can make it a little. Let me go just a little bit bigger. Can you see that at all?
Yeah, that helps.
Okay.
If you hit Control Plus.
Control Plus. Okay. What happened? Nothing.
Never mind.
Okay.
Lee, click on enable editing. There you go. Now the Control Plus might work for you.
Yeah, it did work. Okay. I think you can see everything. What I have here is right here on the left-hand side is the name of the provider type. Okay, not the actual provider, but the name of the provider type. These are the providers that have been using the system and have reported missed or canceled appointments. And the number is how many times they have used it.
And can you
Okay.
only enter one data point each time you use the system, Lee? In other words, if you had 3 clients in one day that missed their appointment, does that come up as 3 on your list, or does that come up as 1?
It would come up as 3,
Okay,
is what I'm trying to say.
yeah, good.
Because this means that a licensed clinical social worker has used the system 6 times.
Okay,
Okay, and you can see that individual dentist at 34 and physicians group and optometrist individually have used it the most. The total there's 248 different providers. That's what actually what this is telling you actually, Sheila, I'm sorry. That is that only one adult day center has used the system. This tells me that one hospital has used it. Hold on a second. I have the other information that you're looking for, however.
So it looks like from this, only one community mental health center has reported.
Yes. I'm going to stop sharing for just a second until I can open this new one, just to make sure that it opens to the there we go. Let's go back and share again. And now find this screen. Where is it? Can you all see that? It's got the list of I know, probably not very well. Hold on.
okay, it's the list of the MCOs.
Yes, ma'am.
Okay,
No, that's not it. Make that a little bit bigger.
oh, that helps. Yeah, oh, good.
So unfortunately,
I can even see that, Lee.
so that's just a raw number of individuals reporting have. And so it's a little hard to not know their total membership to know what that means, but it just shows you there are 12,000 missed appointments.
Okay, so I can tell you that WellCare has the most members at a little over 400,000. And Molina has probably the next, with United Healthcare has the least, Humana, Anthem, and Aetna. Aetna is probably the 4th, and then Anthem. You know, I thought about running some different numbers on here, but not knowing exactly what you wanted to see, it was hard to make the decision. So this count of member IDs, these are individual unduplicated members that were reported.
Okay,
And these members belong to WellCare. Okay, and this is how many times an appointment was missed.
so roughly 9,500 individuals unduplicated missed 12,500 appointments.
Yes, ma'am. Yes,
Okay,
ma'am.
all right, so some missed more than one appointment, obviously.
Yes.
Okay. All right, so that is helpful, I guess, to the MCOs. So the other data would tell us by provider type who's using the system and reporting.
Right.
Yeah,
Exactly.
okay.
This is Nikki from Kentucky River, one of the community mental health centers. I know for us, if I could just speak about our experience, I think this is pretty new, having this form available for tracking purposes.
Yes.
And I think the data is wonderful to have. I don't think it's really been integrated into our folks' workflow yet in terms of the reporting, because it's fairly new, because our staff are spread out, because we're doing telehealth, et cetera. Things take time to get integrated into the workflow to probably have some really good data through this system. Now, if I go pull a report out of my system, to show me about how many missed appointments we have, we usually run close to 30%. But that's integrated into my system, whereas this is another system where somebody has to go put in data. So I think that extra step could be part of the reason for the slow reporting.
Sure.
Yeah, and this is Bart. Similar type question, if there was a way to, like Nikki said, to batch, and send a report without manually coding in every single missed appointment into the system, I think you would get a lot greater compliance. Because Nikki, if you, like you said, 30%, I mean, we're talking about, that's
Very significant, very significant.
thousands a month, just right there.
Yeah.
And that's a lot of manual entry and a lot of staff, time to get this info that's probably already in a system to begin with.
Exactly, yes.
Yeah, we track that. I think, I don't know the number offhand like Nikki does, but I suspect, we all know what that number is. And I still think, and I think this is one point Sheila was, I've been asked, how is this information used? Is it gonna, and I think people's concern is, will the individual get contacted by somebody? You've missed appointments, how come? And I think that's a concern that's been expressed to me as well. And it may not be, it may not happen at all, completely irrational concern, but I've heard that from other folks.
I don't know how the information will be used, but one way it could be used is for managed care companies to offer care coordination, do outreach and find out. Now,
yeah.
Is that an invasion of privacy, or is that
no
about my patient and I'm trying to find out why they haven't been in to see me?
Yeah. And we don't think it's a privacy issue. We just think, is there some negative consequence for the individual?
I do know some providers fire people who miss 2 appointments, which is also inappropriate in this.
Yeah.
So my
Yeah, I think that was my concern, Alan, was, people being labeled in some way if they show up as a chronic no-show or something like that. I mean, we have enough problems with stigmatizing and stereotyping. So Lee, obviously there are member names in here, right?
Yes.
I guess my question is, are the members' names then turned over to the MCOs?
Well, it makes it a little bit difficult to do any coordination without sending their membership back to them to show that they have, they have to have the information to do anything with it. I don't know what they do with it. You would need to ask the MCOs that question.
Yeah, this is Veronica Cecil with Medicaid. I think it is the intent for this information to be utilized by the MCOs to do, just as Dr. Brenzel indicated, some type of outreach. Especially if we're identifying a member that has missed several, there could be something going on, and having the MCOs reach out and check in with that member and see if there's other supports they need. Is it transportation? There's a whole host of things that could be causing the missed appointment. It absolutely is not to stigmatize, and I think we all, and by we I mean from the department to the providers to the MCOs, are just trying to do what's in the best interest of the member and support them. And there is nothing that can be done to the member. So again, this is all about being supportive, being helpful, and just trying to identify, are there other supports that can be provided to the member to assist that they're getting access to the care.
My care, personally, I go to the Ridge for outpatient services, and if I miss an appointment, they try to contact us 3 times. And on that 4th time, if I'm not mistaken, whoever's on here from the Ridge possibly can clarify, but I believe at that 4th time, they do a welfare check and they send someone to the home.
So that's a service that you get, Val, as a regular patient in their outpatient services. Okay. Yeah, the welfare check part of that, I think, is one thing.
Sheila, I know at one meeting that I heard Commissioner Lee talk about this, was that they wanted to be able to do some outreach, I mean, and if we find that, say for instance, transportation is an issue, then make sure that they're hooked up to the transportation benefit of Medicaid to help them get to these appointments. So it's stuff like that I think is what the commissioner's goal was, is just really and truly to help these folks. Like Deputy Commissioner Cecil said.
Yeah. Yeah, and I'm not, please don't hear me as saying that I think anybody on this call or anybody in the department or any of the MCOs are stigmatizing or treating people badly. I think it's just the danger is there of people getting labeled.
And Sheila, it's relatively new. I think there's that piece as well. People are,
let's, I think what I'll do is to ask, maybe November is too early, but maybe in January, the MCOs would have enough time to have a little bit of a sense where they could give a report about, we followed up on X number and, these are the things that we found were keeping people from their appointments, kind of thing. Because I do think that that's a kind of a reverse needs assessment in some ways. And I wouldn't be surprised, Charlie, if it was transportation, because transportation is always at the top of the list in terms of issues. I think somebody just asked here in the chat, Lee, when will these reports be going to the MCOs?
Let me check and see if I can run that down before the meeting ends.
Okay. And was there another comment in the chat that I need to look at?
I think they were both kind of the same.
Yeah, same thing. Yeah, about timing. And who are you sending the reports to, I guess might be helpful to know. Because obviously there's lots and lots of staff at the MCOs and lots of people who would be roughly.
Okay, I'm pretty sure it's not just like going out in an email. So I'm sure that it is transmitted over the secure site the same way we transmit everything else.
Right, Lee, I believe it's going to be on SharePoint for where the MCOs have access to pull the report.
Perfect. Thank you, Angie. I'm going to stop sharing the screen now. Is that okay?
Yeah, that's fine. Thank you very much for bringing that data, Lee. That's helpful.
Certainly. Thank you.
And Angie, that shared point is called SharePoint. What's it called?
Yes, it's SharePoint. It's I guess, lack of a better word, a system that is able to share information with the MCOs that without having to send securely. It's a secure site, I guess is the word I was looking for.
Okay. And another MCO rep is asking, what's the name of the report? Do we know that?
We'll get it, hopefully that answer before the end of the meeting.
Okay. Thank you very much, Lee. I reached out to Abner Rayapati to see if there was any further need to talk about lock-ins for pharmacies and providers. Are you on the call by chance, Dr. Rayapati? I did not hear back from him. You remember he had an issue and Dr. Ali was on last time and gave him some people to check in with.
Unless he's phoning me in, Sheila, I don't see him on the list of participants.
Okay. And what about, is Dr. Ali on
I believe,
Um,
yes, yes.
Wonderful. Thank you so much, Dr. Lee. Is there any, I have not gotten a lot of eruptions from the community about anything having to do with the pharmacy, so it's been nice. Do you have any updates for us, Dr. Ali?
Well, that's certainly good news. No news is good news.
That's right.
Yeah. In terms of lock-in, I don't have much except that we removed Sublocade from the lock-in list, so we shouldn't be seeing any issues with Sublocade. Any other non-Sublocade related lock-in issues can be triaged over to the respective MCO, and they should be able to help with those concerns. I don't have any updates on changes to the single PDL. I did want to note that our P&T meeting is coming up on September 16th at 1 p.m. Keep in mind, these are public meetings, so anyone can attend as a regular attendee. And the link to that meeting is on the Magellan Provider Portal. I'm happy to place it in the chat here as well. In terms of changes to non-PDL drugs, I did want to remind everyone that the non-PDL grandfathering will end on September 29th. So beginning September 30th, those products will no longer be grandfathered, and just another reminder as to which products fall into that list. If the MCO was covering a specific product without a prior authorization prior to 7/1 and now requires a prior authorization, those products are being grandfathered through September 29th. So in other words, these products will show up at the pharmacy with a point of sale messaging informing them that the product is being grandfathered. So prescribers are more than welcome to submit a proactive prior authorization, and we encourage prescribers to do so. We have been hearing that some prior authorizations are not being honored as a proactive prior authorization. So we are working with MedImpact to see what the underlying issues are there. If you see anything and you get a denial that says that it doesn't require prior authorization, but your understanding is that it does, please feel free to reach out and we'll address those issues in a timely manner. I don't have any other prior authorization issues. We get specific member cases from time to time and we're able to resolve them. So if anyone has questions, I'm happy to take those.
Thank you so much, Dr. Ali. Does anybody have, let me just make sure I understand. So this grandparenting, I like to call it, so it's non-sexist. Grandparenting period will end on September 29th. So any of those drugs that would have required a PA will now require a PA.
Right. So if the MCO was not PAing the product and it is now being PA'd as part of the new formulary, it is being grandfathered currently. And after September 29th, it will require a prior authorization. But again, we encourage prescribers to submit proactive prior authorizations so the member can continue therapy with the drug without any interruptions in care.
Okay, so the prescribers know that the deadline is looming and you're asking them to be proactive so people don't get left without their medications, essentially. Okay.
And we've been communicating via lettering. We sent out a communication very recently at the 30-day mark, and we've also sent it out at the 60-day mark as well.
Okay, thank you. Any questions for Dr. Ali? It's wonderful to have you on the call, Dr. Ali, so that if any, medications are so important to our people. We want to be sure they have access. Anybody have any questions for Dr. Ali on anything pharmacy related, access to medications?
So question, let's see if I can ask this question smartly. So if the grandfathering stops on the 29th and it has to be pre-auth on the 30th, will that be, I assume that'll be flagged and folks will see that list when they need that prior auth? Will it go through pretty quickly because there's already that list? Do you know what I'm saying?
Yeah, and that's where we encourage pharmacies, members, and prescribers alike to be proactive. The members can certainly take charge of their health and call their doctor and ensure that the prior authorization has been submitted. We've been communicating with members, prescribers, and pharmacies alike to ensure that the word is out there. Pharmacies can also help by calling the prescriber and ensuring that they're aware that certain products need a prior authorization. And there are certain medications where pharmacies can initiate prior authorizations as well. So it's a collaborative effort at the end of the day.
Yeah, so I think, Val, from the consumer perspective, the issue is to, be watching those meds and checking with your prescriber to make sure that he or she has sent in a proactive prior auth, because we're in the month now. So if you get a 30-day prescription, you got to be ready for the next month, right? Good question. Thank you very much. Any other questions for Dr. Ali? All right, you get off easy today, Dr. Ali. Thank you so much for being with us. We really do appreciate that. And Leslie, this is our age-old question of you. Status update on the waiver for SUD services for incarcerated persons.
Hello, Sheila, it's me again. I met with CMS week before last. Again, I actually talked to Felicia, who's at CMS is kind of my lead person for this incarceration amendment. And she again said, please reiterate to our executive staff, our leadership, and our advocacy, because I reiterated everything she said. And I said, this is what I'm telling people. She said, do not feel bad. It's not negative. There's no bad decisions being made. It's just being visited at a much higher level because so many states are involved now, and they want to make sure that they've got it right before they roll anything out. So I'm just reiterating what she said to me the other day. It's all still positive. And I meet with them on a regular basis every month, and I keep it on the agenda, and I'll keep you guys posted.
Well, that's what I've been telling people. It comes up in our various meetings because people are really anxious. And I said, one of the downsides of being a trailblazer, which is what Kentucky is in this regard, is that we kind of caught CMS without some of the guidance that they needed, as I understand it, Leslie, right? They had not prepared some of the guidance documents and so forth that they would need to have ready for other states.
Yes, that's correct. Such thing as metrics, policy. There's a lot of things that go into an 1115 that a state's held accountable to, and what that would look like, especially the metrics and the monitoring piece.
Okay. So the message is that the guts of the thing, the target population and the interventions and so forth are go. We just aren't going yet. Is that accurate?
That's accurate as far as I know. For they've not given me any indication that they would not allow this in some form. Now they might decide, to have me to modify it in some way, but they have not even provided guidance from the federal public comment period. Those questions, they've not provided me anything even from that yet.
Okay. All right. Well, we will, of course, keep it on our agenda. I think it's permanently in my computer at that spot. So thank you for that. I don't think, Charlie, can you look and see if Dr. John Sullivan is with us?
Let me look here real quick.
Okay, thank you.
John Sullivan?
John Sullivan, yeah.
Nope, I don't see him.
Okay. So this is his issue around 90214 and 99215. So we will try again next time. The 2021 General Assembly Interim Session Task Force. Leslie, the last time you gave us kind of an update. Are you doing that again this time? Or am I?
Sheila, I didn't have any particular things to give you for update this time. Jonathan might be on the call. I'm not trying to put him on the spot, but if not, I can check on those task force and give you any updates that I'm aware of or that I can find out.
Yeah, thank you. We had some excellent presentations in August, really around recovery services and housing. So we had Bridgehaven Mental Health Services in Louisville. We had Wellspring. We had New Beginnings in Lexington. We had a program from Mountain Comp Care, and we had Pathways, CMHC, also presenting. So we've covered a lot of ground so far on that SMI task force. And the next meeting, I meant to look it up. I'll have to look and see when it is because they keep changing the dates of these things. But I'll post it when I see it. So they will meet in September, October, and probably try to wrap it up in November in terms of September 21st. Yeah, you're right, Sarah. Thank you. September 21st at 3 p.m.
And Commissioner Morris has been asked to speak, as well as I've been asked to present on state hospitals. So,
oh, great.
We'll be on the agenda for that September 21st meeting.
Okay.
He did.
What is Commissioner Morris going to speak about, Alan?
I'm not 100% sure, but I think there was a specific request from the committee regarding Tim's Law and the
Tim's Law, yeah.
Louisville pilot.
Yeah.
Sheila, this is Leslie. I'll be presenting on our initiatives towards an SMI SED waiver.
Excellent.
Great. And Alan, you're going to talk about the psych hospitals, the state psych hospitals and that system.
I think so. We had some very specific question about average length of stays, number of people, how we're coordinating discharge follow-ups and things like that. So I think a specific member had some specific questions.
Great, thank you. For those of you who are not following that, it's available to watch live on the Legislative Research Commission's YouTube channel, and I typically have sent out that link. But if you go to the LRC website, which is www.legislature.ky.gov. Oh, Marcy put the link in there for you. Thank you, Marcy. You get good coverage. I mean, you can't speak, so it's not like being, signing up and being able to speak. But we've had some good, excellent consumer stories, which is always helpful, and we appreciate that. Is there any updated prior authorization guidance? I haven't seen anything come out for probably 2 months, I guess. Any changes?
There's nothing has changed as far as behavioral health goes.
Okay, thank you. New recommendations to the MAC, and I would like to propose that we recommend to the MAC that prior authorizations continue to be suspended for all behavioral health services through the end of this fiscal year, which is June 30th of 2022. So I will make that motion. Is there a second from a voting member of the TAC?
Second, Steve Shannon.
Okay. My reasoning for taking it into June 30th of 2022 is that I think we're still going to be dealing with the behavioral health sequelae of COVID and Delta. And, we thought we were coming up on the other side, and I'm not so sure that we are. So that's my recommendation. I'd like to hear any discussion from any of the voting members.
I agree, Sheila.
I agree.
Yeah. This Delta surge, I think, has caused a lot more anxiety for many people going
Yeah.
forward. And
Actually,
land is coming, so I think it's a concern.
Yeah.
we
land-
actually closed participation station last Friday, again, going back to virtual programming.
Yeah.
Yeah, I think, and we're still seeing, increased calls to the suicide line, the overdose
Yep.
deaths are still up and so forth.
We can't keep up on our warm line at all.
Yeah, right. Yeah. So motion's been made and seconded. All those in favor of making that recommendation to the MAC signify by saying aye.
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 Great, thank you. Any other recommendations to take to the MAC at their September 23rd meeting?
This is Steve Shannon. I think just let the MAC know about an SMI waiver, that we support that. We've talked about it a lot here, variety of settings, the SMI task force, last time it was testimony, maybe it was HCB, but P&A supported the SMI waiver. Other folks have. So I just think make that recommendation so we go on record as supporting an SMI waiver, SMI SED waiver.
That's a great idea.
Is that a second, Diane?
Yes, I'll second it.
Okay.
Only thing I would add to that conversation is that I'm not seeing a lot of focus in any of the policy committee meetings that I've been in on pediatric mental illness, and it's surging as well.
Yeah, who was that just made that comment?
Rhonda Blandford, NAMI Louisville.
Yeah, that's very much. Well, I think we're talking, aren't you talking, Steve, about SMI, SED?
Mm-hmm.
Yeah.
That's what Leslie Hoffman said. So
Yeah. So that would be the severe emotional disturbance in kids. But yes, you're right, Rhonda. There is certainly much more of that. Any other comments on that motion? So we have a motion and a second to recommend to the MAC that we support the development of an SMI SED waiver. All in favor signify by saying aye.
Aye.
And opposed and abstaining. Any other recommendations for the MAC? Okay. We have several items that we're going to carry over from this meeting. So we seem to have an ongoing thing. And if we get some good data back from Medicaid, we may be able to put that on the November meeting date to see what the Medicaid data looks like as far as the targeted case management goes. So that's pretty exciting to think we could get our hands on some pretty targeted data. The next MAC meeting will be by Zoom, September 23rd. It's a Thursday, starts at 10. They've been ending early, but it is scheduled to go until 12:30. And then our next BH TAC meeting is November the 3rd at 1 p.m. Eastern via Zoom.
You all had last time, if I recall correctly, had voted that you would basically follow, as far as Zoom or in person, that you would follow what the MAC was doing?
Yes.
Okay. Then, because I was just going to say, and you do have the November, I didn't realize that November would be your last meeting until I just started talking, but I was going to ask that I would hope that maybe we would just stay Zoom for the rest of the year, because with this Delta variant and so forth.
Well, and I'm waiting to see, Charlie, what's going to happen with the session opening on January 4th. I think we all thought that we would be back up in Frankfurt like we used to be. You all remember those days.
Right.
And I'm not at all sure that we're going to be back up there in any kind of numbers or anything else. So yes, this will take us via Zoom all the way through 2021. And then we'll kind of see at that point when we meet in November, but probably we'll start off via Zoom you know, we've had tremendous participation. I think at one point we had 73 people on the Zoom call. And it's, of course, it's so much easier without having to drive and so forth. Not as much fun and not as much networking, and it's hard to keep track of everything, but we certainly appreciate everyone participating and being on it. And we'll be in touch with Tom Walton. I think he presented some very interesting, thoughtful data. We'll get that PowerPoint out to you, and let's see what we can do. I think folding it in some way in an SMI, SED waiver around housing would really make some sense. So good stuff. Any other questions or anything else that anybody wants to bring? I'm letting you all go early. You got 20 more minutes that you could just fritter away here. Hardly ever happens. All right, Charlie, thanks as always, and thanks to all the DMS and DBH, DID folks that are on, our voting members and the MCOs, and all of you good behavioral health folks. Stay safe and healthy. Have a good Labor Day weekend. Don't labor on Labor Day. And we'll see you soon. Thank you.
See y'all.
Take care.
Bye.
Bye.